Hello everyone. I welcome you all to this ECG lecture series. ECG is one of the very important diagnostic procedure which is required to diagnose the cardiac conditions. So the knowledge on this particular ECG is very much required to diagnose the acute conditions and give appropriate therapy on time. So let me just start this particular session with ECG basics. Now what is that I will be discussing in the ECG basics? In the ECG basics, I will be discussing various waves of the ECG. I will be discussing about the ECG paper. I will be discussing about the ECG machine, and then I will be discussing what can be the errors in the machine and what can be the errors in the leads placement that give us a false diagnosis. And in this session, I will be also discussing about the leads of the ECG. Now, let us start with the session. So, this is the normal ECG, right? So, what does this normal ECG contain? The normal ECG, if you see the waves, right? If you see the waves, we have the P wave, then we have the QRS complex, then the T wave. And apart from that, in between the waves, we also have the segments. Now, at this point, you need to remember the two important aspects. One, you need to understand what you mean by the word interval, and you need to understand what you mean by segment. So you take the interval, like for example, PR interval. PR interval is that which has the waves, right, which has the wave, and along with that there will be presence of isoelectric baseline. That is what is your interval. And if you take segment like for example PR segment, or you take ST segment, right, that contains only isoelectric baseline. Right, that contains only isoelectric baseline. So that is what is the difference between the interval and as well as the segment. Now let me just give you what exactly is the etiologies of these particular waves. Why do you have P wave? Why do you have QRS complex? And why do you have T wave? And why do you have these particular segments? All this, let me just give you a picture. So if you take this image, in this image you can see the P wave. The P wave, it is due to atrial depolarization. Right, it is due to atrial depolarization. Whereas you take the QRS complex. The QRS complex, it is due to ventricular activation or ventricular depolarization. Right, ventricular activation or ventricular depolarization. And you take the T wave. The T wave is due to ventricular repolarization. Right, ventricular repolarization. Now what is that you are missing? The one which is missing is the atrial repolarization. Remember, the voltage which is being produced due to atrial repolarization is very less, that is less than 100 millivolts. And because the potential which is generated due to atrial repolarization is less than 100 millivolts, that particular potential is overlapped by the QRS complex. So you don't have a separate wave for atrial repolarization. So to summarize, P wave is due to atrial depolarization, QRS complex is due to ventricular depolarization, and T wave is due to ventricular repolarization. Now after having discussed about this, now let me just show you a question here. Right, you see this question. The marked part of the ECG, that is X, right? So this is your X. The marked part of the ECG called as X points to which phase of the cardiac action potential? So this is a multiple choice question which is integrating your ECG complex and as well as the cardiac action potential. Now, in the cardiac action potential, what are the phases you have? You have phase 0, you have phase 1, phase 2, phase 3 and as well as phase 4. Now, what is the question asked? What is this particular X points towards? Phase 0, phase 1, phase 2, phase 3. Remember, the point X, right? The point X on the ECG, it corresponds to phase 2, right? It corresponds to phase 2. What is this? And let me tell you. Now, you see the explanation. You would have phase 0, phase 1, phase 2, phase 3, I will explain you everything now. Now, you take phase 0. Phase 0, this corresponds to ventricular depolarization. Right, this corresponds to ventricular depolarization. And remember, this particular phase 0 is during which there will be entry of the sodium into the cells. And because of the entry of the sodium into the cells, there will be activation of the ventricle where there will be ventricular depolarization. So, your phase 0, this will correspond to your QRS complex. Right, this will correspond to the QRS complex. And you take phase 1. Right, you take phase 1. So remember, this particular phase 1, that is the point when the repolarization begins. Okay, so during phase 1, there will be start of the repolarization. So that means what? During phase 1, right, during phase 1, there will be potassium efflux which will begin. Right, it will begin. And immediately, what will happen in phase 2? In phase 2, during phase 2, there will be potassium exit and calcium entry into the cell. That means what? A positive ion is moving out and a positive ion is entering. That will give rise to a phase called as the plateau phase. So, that will give rise to a phase called the plateau phase. Now, this particular plateau phase, that is phase 2, that will correspond to your isoelectric baseline, that is X. Right? That will correspond to your isoelectric baseline X, which is nothing but ST segment. Right, which is nothing but ST segment. So X corresponds to ST segment. And you take the phase 3. During phase 3, there will be complete potassium efflux. So this is your phase 3 is your active repolarization. So your T wave, right, your T wave, it corresponds to your phase 3. So now to summarize everything, QRS complex is corresponding to your phase 0 of action potential. Next, you take phase 2. Phase 2, it corresponds to your ST segment. And phase 3, it corresponds to your T wave. Right, phase 3 corresponds to your T wave. Now, phase 1, it will be in between your phase 0 and as well as phase 2. That means, like, your QRS complex is corresponding to your phase 0 and ST segment is corresponding to your phase 2. Now this J point, right, this J point, it corresponds to your phase 1. Okay, what is J point? J point is, this is your J point. That is the end of S wave starting of your ST segment. This is what is your J point. Okay, so that was the slide which was integrating your cardiac action potential and as well as the ECG complex. Now, apart from this PQRST complex, you have an additional wave called as the U wave. Let me show you that. So this is the U wave. This U wave, why is this due to? Always remember this particular U wave which occurs after your T wave. Okay, this is your T wave. After the T wave, you will have U wave. And this is due to delayed repolarization of papillary muscles of the heart. Right, delayed repolarization of papillary muscles of the heart. Okay, so this is what is your U wave. Okay, and what will be the duration of the U wave? The duration of the U wave, it is less than 40 milliseconds. And the amplitude of the U wave, it is 0.5 mm. Right, it is around 0.5 mm. And U wave, it can be physiological also. Right, like in clinical scenarios like bradycardia, sinus bradycardia, you can have this U wave. But what are the pathological conditions where you will have the U wave? The pathological conditions where you will have U wave is in conditions like hypokalemia. In hypokalemia, you have the appearance of this particular U wave. Now, so this is your normal PQRST complex. Now let me just give you little more details of the QRS complex. Right, let me just give you a detail of the QRS complex. So if you take the QRS complex, I have dissected the QRS complex. Right, you have Q wave, R wave, and then the S wave. So how is your QRS complex now? You have a negative complex. The Q wave is a negative complex. Now the question is, why the Q wave is the negative complex? Right, the question is why the Q wave is negative complex, why R wave is a positive complex, why S wave is the negative complex again. Let me explain you that in detail. Okay, right, if you see this slide over here, you can make out, okay, you place the lead here. Right, so which lead will be there at the apex? Your lead 2. Right, I'll explain you in detail about the leads, but for now just remember, you will have lead 2 at the apex of the heart. That is the reason why. And the wave of depolarization or your direction of depolarization or your axis of the heart is towards your lead 2. Towards your lead 2. And that is the reason why lead 2 is called as the standard lead, or lead 2 is considered as rhythm strip. Okay. Now our discussion here is why Q wave will be the negative wave. First of all, you should understand that Q wave is due to septal depolarization. Right, it is due to septal depolarization. Now, how will be the septum that gets depolarized? Septum will be depolarized from left to right. Right, septum will be depolarized from left to right. That means left to right. Lead at the apex, and the wave of depolarization, right, and the wave of depolarization is moving away from the electrode. So when the wave of depolarization is moving away from the electrode, you will have a negative complex. So in the ECG, you have to remember one concept. What is that? For example, you take this as the electrode, and if the wave of depolarization is moving towards the electrode, you will get a positive wave. And if the wave of depolarization is moving away from the electrode, you will have a negative wave. Right, you will have the negative wave. Is that clear? So the concept is same here also. Here, the wave of depolarization is moving away from the electrode in the septum because septum is depolarizing from left to right. And that is the reason why you have the Q wave being a negative wave. Subsequently, you see here the R wave. How is your R wave? R wave is a positive wave. Why? I'll tell you. R wave is due to ventricular wall depolarization. Right? R wave, it is due to ventricular wall depolarization. So, what you should remember is the ventricular wall depolarization, the direction of your ventricular wall depolarization, it is towards the electrode. So, when the ventricular wall depolarization axis or direction is towards the electrode, you will have a positive wave. Then you take the S wave. S wave is again negative wave. Negative wave means what? The direction of depolarization should be away from the electrode. So S wave, right, remember S wave, that is due to depolarization of the base of the ventricle. What is the base of the ventricle? This is your base of the ventricle. Okay, so when the depolarization of the base of the ventricle is occurring, the wave of depolarization is moving away from the electrode or away from the lead. That is the reason why your S wave is a negative wave. That is the reason why S wave is a negative wave. Alright, next. And so I have discussed in detail why QRS is negative, positive and negative. Then you take P wave. P wave is what again? It's a positive wave. Why? Because the same story again. You see, this is the electrode, you place the electrode here. And how is the wave of depolarization going? The wave of depolarization of the atria is moving towards the electrode. P wave is atrial depolarization. And atrial depolarization is going in the direction towards the electrode. So you will have a positive wave. Right? You will have a positive wave. And you take the T wave. T wave is ventricular repolarization. Right? T wave is ventricular repolarization. Now, how will be the direction of ventricular repolarization? Remember, the ventricular repolarization it occurs from epicardium to endocardium. Right? It occurs from epicardium to the endocardium. So when repolarization is occurring from epicardium to endocardium, you see how is it? This will be the direction of repolarization. And this is your electrode. Right? This is your electrode. So repolarization is moving away from the electrode. Again, you listen the concept. If the wave of repolarization, right? If the wave of repolarization, if it is towards the electrode, you will get a negative wave. Right? You will get a negative wave if the wave of repolarization is towards the electrode. In case, if the wave of repolarization is away from the electrode, right? In case, if the wave of repolarization is away from the electrode, then in such case, you will have a positive wave. Same thing is happening here also. Here what is happening? The wave of repolarization of your ventricle is moving away from the electrode. So when the wave of repolarization is moving away from the electrode, you will get a positive wave. That is nothing but your T wave. So that is the concept behind why you have a positive wave that is above the isoelectric baseline and why you have a negative wave that is below the isoelectric baseline. Right? So this is the story of the PQRST complex. If the origin of impulse is from the SA node. Right? If the origin of the impulse is from the SA node. Now for suppose, right, for suppose, if the origin of the impulse is not from the SA node, right, then in such case, like for example, if the origin of the impulse is like for example in the ventricle, what will happen? Right, let me show you that. Right, so you take this ECG strip. What is that abnormality you are able to make out? You are able to make out that there is wide QRS complex. Right? I have shown you normal QRS complex. You see here. So if you take the normal QRS complex, this is your normal QRS complex. Normal QRS complex, the duration is 70 to 100 milliseconds. Whereas if you take the QRS complex here, it's a wide QRS complex. The duration is more than 100 milliseconds. So what is this milliseconds and all? I will discuss in detail when I am discussing the ECG paper. Okay. Now, you will have this particular type of prolonged QRS complex in a clinical scenario of bundle branch blocks, right? You have right bundle branch and as well as left bundle branch in your conducting system of the heart. Okay, you see this. This is your SA node and this is your AV node, and you have the bundle office, and then you have right bundle branch and as well as the left bundle branch. Now, if there is block in any of these bundle branches, right, if there is block in any of these bundle branches, then in such case, in bundle branch block, you will have this wide QRS complex, right? You will have this wide QRS complex. Okay, right. Now, after having discussed about the normal ECG complex, now let me discuss in detail about the ECG paper. Okay, so this is what is the ECG paper, right? So you have some horizontal lines and you have vertical lines as well on the ECG paper. And in the ECG paper, you have certain large boxes, right? And you have some small boxes. Right? You have some small boxes. Okay. Now what is this? I'll tell you. You take x-axis. This is your x-axis. X-axis on the ECG, right? X-axis on the ECG, it represents the duration. Right? Y-axis on the ECG represents the voltage. Represents the voltage, or we call it as amplitude. Right? Or we call it as amplitude. Okay. Now, what is the duration of one small box? What is the duration of one large box? And at the same time, how to calculate the voltage and or how to calculate that particular amplitude? Let me discuss that now. Now, you take the duration of one small box, right? If you take the duration of one small box, that is around 40 milliseconds, right? So consider this is a large box. In this, you have small boxes. Right? So one small box, this is 40 milliseconds. Okay. In one large box, how many small boxes are there? 5 small boxes are there. So you multiply this into 5. So how much it becomes around? 200 milliseconds. So one large box is 200 milliseconds, or if you take that in seconds, that will be 0.2 seconds. Right? That will be 0.2 seconds. Or if you take 40 milliseconds into seconds, that is 0.04 seconds. Right? 0.04 seconds. Is that clear? So that is about the duration of one small box and as well as one large box. And this is about the ECG basics on the ECG paper. Now, at the same time, you should also know the y-axis. Right? At the same time, you should also know the y-axis. Remember, one large box is equal to 5 mm. That means what? One small box So 1 large box is equal to 5 mm. That means, like, in 1 large box, how many small boxes are there vertically? 5 small boxes are there. So 1 small box in the ECG paper will be equal to 1 mm. Right? Will be equal to that of 1 mm. And what is actually your y-axis telling? Y-axis is telling you about the voltage. Now 1 large box is equal to 0.5 millivolts. That means 5 mm is nothing but 0.5 millivolts. Whereas if you take 2 large boxes will be equal to 1 millivolt. That will be equal to 10 mm. Okay, that will be equal to 10 mm. Okay, so I'll repeat this again. X-axis is duration, y-axis is voltage. X-axis, 1 small box 40 milliseconds, 1 large box 200 milliseconds. And y-axis is the voltage. 1 small box is 1 mm, 1 large box is 5 mm. And if you take the voltage, 1 large box is equal to 0.5 millivolts and 2 large boxes will be equal to that of 1 millivolt. Okay, so this is about the ECG paper. And the other point is, you need to understand, or you need to know, what is the speed of the ECG paper in the ECG machine, right? You see here. So if you see this question, the usual paper speed of ECG in the ECG machine, 25 millimeters per second, 50 millimeters per second, 75 millimeters per second, 100 millimeters per second. Remember, the usual paper speed in the ECG machine, it is 25 millimeters per second. Right? 25 millimeters per second. This is very, very important. And if a different speed is used, calculations will have to modified appropriately. Right? Calculations have to be modified appropriately. Now the question is, for suppose, what happens if the speed is increased? What happens if the speed is decreased? Right? Let me tell you. For suppose, if the speed is increased, right? Normal speed is how much? 25 millimeters per second. Right? Now, through this ECG machine, if the paper is moving fastly out, right? If the paper is moving fastly out, then in such case, what will happen? You just imagine by yourself. When the paper is moving out fastly, the electrical activities picked up by the ECG paper will be reduced. Like, for example, the concept is very simple, right? You are being chased by someone and the person, whoever is chasing you, is beating you. Okay. For suppose you run out of him very fastly, the number of hits what you get is less. But when you go away from him very slowly, the number of hits what you get by him will be more. The same concept. That is, when the ECG paper is moving out very fastly from the ECG machine, the number of electrical activities what it will take up from the heart is less. So the concept is that if the paper moves out speedily with, for example, at a speed of 50 millimeters per second, actually not, what should be the normal speed? 25 millimeters per second. But if the paper moves out at a speed of 50 millimeters per second, in such case, remember, the ECG appears that the individual has bradycardia. Right? The ECG appears that the individual has bradycardia. Whereas if the speed is decreased. Right? Whereas if the speed is decreased. If the speed is decreased, right? What did I tell you? When you are running away from the person whom they're chasing you, when you are moving away from him slowly, the number of hits what you get is more. The same thing is in your ECG paper also. When ECG paper is coming out of the ECG machine very slowly, the number of electrical activities what it will take will be more. So when the speed of the ECG paper is decreased in the ECG machine, it appears that the individual has tachycardia. Like for example, the speed is 12.5 millimeters per second. So how does it appear? It appears that the individual is having tachycardia. Right? It appears that the individual is having tachycardia. Right? Let me show you the ECG also, okay? Right, you see this. Now, this is the ECG paper with a speed of 25 millimeters per second. That is a normal speed. Right? That is a normal speed. Okay? Now, the point is, when the ECG paper is going at a speed of 25 millimeters per second, the heart rate, it is around 150 per minute. How to calculate the heart rate? I will tell you. Right? Subsequently, I will tell you how to calculate the heart rate. But trust me, in this ECG paper, when the speed is 25, it is 150 per minute. Now, the same patient, if the ECG machine is run at a speed of 50 millimeters per second, you see how much is the rate in this individual now? The rate is around 72 per minute in this patient. Same patient, but the speed of the paper coming out of the ECG machine has been increased. So it appears that the individual is having bradycardia. Okay. So before considering that there is some abnormality in the patient, first you need to look at the ECG paper at what speed it is coming out. Always in one corner, the speed will be mentioned on your ECG paper. If it is 25 mm per second, then it is correct. If it is 50, that means the problem is in the ECG machine. Right? So, in the same way, like for example, we will take an ECG with a speed on the lesser side. Now, for suppose you take a ECG paper with a speed of 12.5 millimeters per second. When the speed of the paper is like 12.5 millimeters per second, it appears that the individual is having tachycardia. Right? You see in this patient, it is the ECG of some different patient. It is not the same patient what I have shown you the previously. Right? So the heart rate in this ECG paper, it is around 150 per minute. Okay. So now the concept is that if the paper is moving fastly out of the ECG machine, it appears that there is bradycardia. If the paper is moving slowly out of the ECG machine, it appears that there is tachycardia. Right? So that is what you need to know about the ECG speed, ECG paper speed. Next, the other important basics what you need to know is about the calibration of the ECG. Right? Calibration of the ECG. What is the standard calibration? Standard calibration is 1 centimeter. So 1 centimeter is how much? That is 10 mm. Right? 1 centimeter is nothing but your 10 mm. So 10 mm is nothing but your 1 millivolt. That is the standard calibration. You should not have under calibration. You see, this is actually only 5 mm. 5 mm means 0.5 millivolt. So this is your under calibration. And if you take this strip here, this is like almost 15 mm. So this is calibration is increased, over calibrated. Right? Over calibrated. Okay. So that calibration can be set in the ECG machine itself. And the calibration what you have to set is 1 millivolt or 1 centimeter or 10 mm. That means it should occupy 2 large boxes. Now, these two things always you should see whenever you take the ECG in your hands. What is the speed? Is it 25 millimeters per second? Is it there or not? Number 2, you have to look for the calibration. That should be 1 centimeter. If the calibration is wrong, then you can get abnormal ECG. If the speed is wrong, you can get the abnormal ECG. Now, let me tell you Like if it is under calibrated, what will happen? If it is over calibrated, what will happen? But before that, let me show you that where do you have the representation of calibration in a normal ECG. Okay, you see this is a normal ECG. Okay, in this normal ECG, right, on the left hand side you will have the normal calibration. Right, you have the normal calibration. You see how much it is occupying? It is occupying two large boxes. That means 10 mm. Right, this is a properly calibrated ECG. So now what is our question? Our question is that what happens, right, what happens if the calibration is increased? What happens if the calibration is decreased? Let me show you both of it. Calibration increased, like for example you have put a calibration of 15 mm, 20 mm. In such case, you will have the ECG complexes with greater amplitude. Let me show you that ECG. So you see this ECG, you have the complexes, very large complexes, right? So if you take the calibration here, the calibration here is 2 millivolts, that is 2 centimeters, right? 2 centimeters. Okay, so this is the effect of over calibration. So what is that you will have in over calibration? In over calibration, you will have the presence of high amplitude, or you will have large complexes. Right, you will have large complexes. This is what is the effect of the over calibration. All the complexes are large compared with an ECG recorded with the correct calibration. That is what you will have in case of an over calibrated ECG. And you see the, right, you see the other ECG, right? If you take the calibration here, how much is the calibration? It is just 5 small boxes. That means it is 5 mm. Right, that means it is 5 mm. That means 0.5 millivolt. Right, that means 0.5 millivolt. So this is your under calibrated ECG. So in case of under calibrated ECG, what is the effect of under calibration? The effect of under calibration is you will have low voltage complexes. You will have small complexes. You can see here the complexes all are very small, right? Very small complexes. Okay, so you will have small complexes compared to that of normally calibrated ECG. Normal calibration is 1 millivolt. Okay, here it is only 0.5 millivolt. So this is about the basics of the ECG paper. ECG paper speed and as well as what is the calibration. Now, after having discussed about the ECG paper, now let me discuss about the ECG leads. Right, let me discuss about the ECG leads. Now, if you take the ECG leads, we have, right, we have a 12 lead ECG. Right, we have the 12 lead ECG. Now, what are these 12 leads? We have 3 limb leads, that is lead 1, lead 2, lead 3. These are limb leads. Then we have 3 augmented leads, that is AVR, AVL and AVF. These 3 are your augmented leads. Then we have 6 chest leads. And what are your chest leads? That includes V1 to V6. Right, I'll discuss these leads in detail. Right, I'll discuss about these leads in detail. But remember, the ECG what we do is a 12 lead ECG. Right, 3 augmented leads, 3 limb leads and 6 chest leads. Now what does this lead do? Lead is the one which will measure the potential difference between the two electrodes, right? You see, this is an electrode placed on left arm and this is an electrode placed on the right arm. Now what does the lead do? Lead is the one which will measure the potential difference between the right arm and as well as the left arm. That is what is the function of that particular lead by which it will calculate the electrical activity of the heart. What actually is your ECG? ECG is nothing but it is measuring the electrical activity of the heart, right? The heart is like contracting and relaxing. The mechanical events of the heart are being converted into electrical energy and that electrical energy is picked up by the ECG. That is what is being measured in the ECG. And that is what is being done by your leads. Okay. Now, let me discuss about these leads in detail. So, you take this question. Which leads are the bipolar leads? Limb leads, augmented leads, chest leads, all the leads are bipolar leads. Remember, that is your limb leads. These are your bipolar leads. Augmented leads and chest leads, these are unipolar leads. So that is how the question can be asked. Now what do you understand by the word bipolar leads and what do you understand by the word unipolar leads? Let me explain you. So first let me take up the limb leads. Okay. So limb leads, what did I tell you? You have lead 1, lead 2 and then lead 3. Let me show you that. So you take the lead 1. Lead 1, so limb leads are what? They are your bipolar leads. That means limb leads are those which will measure the potential difference across the two ends. Right? You take lead 1. Lead 1 is measuring the potential difference between right arm and as well as the left arm. Right? It is measuring the potential difference between right arm and as well as the left arm. That is lead 1. Lead 2, it is measuring the potential difference between the right arm and as well as the left lower limb. Lead 3, it will measure the potential difference between the left arm and as well as the left lower limb. That is what is your lead 3. So limb leads are bipolar leads. Lead 1, lead 2, lead 3. Whereas you take AVR, AVL, AVF. Right, you take AVR, AVL, AVF, that is augmented leads. Augmented leads, they are unipolar leads. Let me show you that. The word itself tells you augmented leads. That means they will just only augment, right? They will just only they will just only augment. That means they will enhance the potential across that particular lead. You take AVR. AVR is the one which will increase the potential difference across the right arm. You take AVL. AVL is that which will augment the potential difference across the left arm. You take AVF. AVF is the one which will increase the potential difference across the left lower limb. AVF means foot. So your augmented leads, they are your unipolar leads. Right? They are your unipolar leads. And to tell you in detail about the limb leads, what did I tell you? Limb leads are bipolar leads. You take lead 1. Lead 1, I said you it will measure the potential difference between the right arm and as well as the left arm. So it is in this direction. That means left arm it will be positive and right arm will be negative. And you take lead 2. Lead 2, it will measure the potential difference between right arm and as well as the left arm. So that means in lead 2, positive electrode will be left lower limb and negative electrode will be right arm. And you take lead 3. Lead 3, it will measure the potential difference between the left arm and as well as the left lower limb. right? Left arm and left lower limb. That means left lower limb will be positive and left upper limb will be negative in case of lead 3. In case of lead. Okay. So these are your bipolar leads. Now the next point is you need to know about the chest leads. Chest leads are also unipolar leads. Chest leads are also unipolar leads. And at the same time, we have totally 6 chest leads. You should know how to place that particular chest leads. Where to place that particular chest leads. That is very, very important multiple choice question as well. Let me show you that. Right? So this is how the chest leads are placed. First of all, you should understand. So why are we using 12 leads for measuring the electrical activity of the heart? Why? Because the heart is a 3-dimensional structure, right? The heart is a 3-dimensional structure. And heart being a 3-dimensional structure, one electrode or one lead cannot measure the potential difference of the entire heart. If at all, if the potential difference or the electrical activity has to be picked up by the electrodes of the entire heart, you require 12 electrodes or 12 leads to pick up the electrical activity of the entire heart. And that is the reason why you require 12 leads. Right? So to pick up the electrical activity of the entire heart, anterior surface, posterior surface, inferior surface, lateral surface, right ventricle, you require 12 leads to pick up the electrical activity of this entire heart. Now you take the chest lead. So how do we place the chest leads? This is how we place the chest leads over the chest. But you need to know in which intercostal spaces they are being placed. Let me show you the image. Right. So you take V1. V1, it is placed in the 4th intercostal space to the right of the sternum. V2, it is same placed in the 4th intercostal space but to the left of the sternum. We don't place V3 immediately. We initially place V4. Where do we place V4? V4, it is placed in the 5th left intercostal space in the mid-clavicular line. Right? 5th left intercostal space in the mid-clavicular line. And in between V4 and V2, we place V3. Then you take V5. V5, we place it in the same level of V4. That means in the same 5th left intercostal space, but in the anterior axillary line. And you take V6. V6 is placed in the same 5th left intercostal space, but in the mid-axillary line. Right? In the mid-axillary line. Okay. So this is the placement of your V1, V2, V3, V4, V5 and as well as V6. And when do we place V7? V7, if the leads are placed on the right side. We will discuss that later. But now let me show you the same thing over the surface of the heart now. Right? So this is your surface of the heart. You just imagine now, V1 and V2, they are picking up the electrical activity of your right side of the heart. So V1 and V2, they are called as right-sided leads. Right? They are called as right-sided leads. And V3, V4, V5, V6. V3 and V4, they are picking up the electrical activity from the septum. These are called septal leads. V4 and V5 and V6, they are picking up the electrical activity from the lateral wall. So V5, V6, they are called as lateral lead. Right? They are called as lateral leads. Now, what you should know is, sir, you have said 12 leads are there. Which particular lead is representing which surface of the heart? Right? Which particular lead is representing which surface of the heart? Let me just show you that. Now, you see this septal view. That means the leads which are picking up the electrical activity from the septum. V3 and V4. The leads which are picking up the electrical activity from the anterior surface of the heart, V1 to V4, right? V1 to V4. What do you mean by the word V? Ventricle. You take lateral leads. Lateral leads are V5 and V6. And not only V5, V6, even your limb leads and even your augmented leads, they also pick up the electrical activity from the lateral surface of the heart. And what are those? Your lead 1 and as well as AVL. Right? Lead 1 and as well as AVL. They will pick up the electrical activity from the lateral wall of the heart. And you take the inferior leads. The leads which will pick up the electrical activity from the inferior wall of the heart is, that is, lead 2, lead 3 and AVF. Right? Lead 2, lead 3 and AVF. Okay? You see this. Okay? You see this is your inferior surface of the heart. Lead 2, lead 3 and as well as AVF. They pick up the electrical activity from the inferior surface of the heart. And you see this is your lateral wall of the heart. And from the lateral wall of the heart, I said you lead 1, AVL, V5, V6, they pick up the electrical activity from the lateral wall of the heart. Now, you take the posterior leads. Posterior leads are that they include V7, V8, V9. Actually, we don't add any 3 more leads to V1, V2, V3, V4, V5, V6. What we do, that V1, V2, V3, we will just replace. V1, V2, V3 is placed over the same thing in a way of, I'll just tell you, V1, V2, V3. They are replaced to a position of V4, V5, V6. Whereas your V4, V5, V6, they are replaced to the position of V7, V8, V9. The same thing, we will just replace them. Now, what is the use of keeping the leads posteriorly? V7, we keep in the posterior axillary line. V8, we keep it in the scapular lines. V8 and V9, we keep them in the scapular lines. What is the purpose of it? The purpose of keeping the leads in V7, V8, V9 is to pick up the posterior wall MI. Right? To pick up the posterior wall MI. So these are the respective leads and as well as the respective surfaces from which they will pick up the electrical activity. Right? So let me just show you an ECG corresponding to the leads and as well as their surfaces. That is, right. So you see this ECG, lead 1, AVL, V5, V6. They are your lateral leads. Lead 2, lead 3, AVF. They are your inferior leads. Then V1, V2, V3, V4. They are your anterior leads. And separately, V3, V4 are septal leads. V1 and V2, they are your right-sided leads. Okay. So this is about corresponding leads and their surface. That means what? For example, if the individual had inferior wall MI, then where will you have the changes? You will have the changes in lead 2, lead 3 and AVF. For example, if the individual had lateral wall MI, where will you have the changes? In lead 1, AVL, V5 and V6. For example, if the individual had anterior wall MI, where will you have the changes? V1, V2, V3 and V4. So why we should know this is because to make out where exactly is the pathology. Is it in the anterior wall? Is it in the lateral wall? Is it in the inferior wall? Right? So after having discussed about the leads and their corresponding surfaces, now let me show you some ECGs with artifacts. Okay. Now you see this ECG, right? In this ECG, you can make out that there are some abnormalities. You see this? This is an abnormality. This is also an abnormal complex. This is also an abnormal complex. But in between, you are having normal complexes. In between, you are having normal complexes. Now, what is the diagnosis of this ECG? This is the ECG due to poor electrode contact. If the leads are not placed properly over the chest wall, then you will get this bizarre pattern ECG. Right? You will get this bizarre pattern ECG. Right? So, in this, the problem is not within the patient. The problem is in the leads what you have placed over the chest wall. Okay? Next. Now, you see this is another ECG abnormality. Right? What are you noticing? You're noticing there are some thick lines in between. Right? There are some thick lines in between. What is this? This is the effect of electrical interference. I'll tell you what is that. Okay? This is the effect of electrical interference. Now, what is this electrical interference? That is what you should understand is, like for example, you have placed the individual over the bed and you have placed the ECG electrodes and ECG leads and you are taking the ECG. But meanwhile, right? Meanwhile, adjacent to the patient, right, there is one pulse oximeter. There is one defibrillator on other side. And there are 2-3 mobile phones on the adjacent to the bed or in the pocket of the patient. In such case, what your electrodes will do? Electrodes will pick up the electrical activity of this surrounding objects also. Right? The electrodes will pick up the electrical activity of the surrounding objects also. Right? So you have placed the patient, you have placed the electrodes. Surrounding him, you have placed many electrical appliances which will be generating the potential. Pulse oximeter is there, right? Defibrillator is there. 2-3 mobile phones are there. In such case, when the electrodes are picking up the electrical activity of surrounding objects, then you will get these particular thick lines. Then you will get these particular thick lines. Is that clear? Next. Now I'll just show you, and this is again an artifact. There is no problem in the patient, okay? Now you take one more ECG. I mean, there is no proper isoelectric baseline, right? So you are having complete zigzag, right? This is the ECG taken from a subject who is not relaxed, right? He is shaking, right? He is completely shaking, right? He is shivering when you are taking the ECG. Then in such case, you will have the ECG with no proper baseline, right? With no proper baseline. So this is again an artifact. So this is what? This is effect of shivering, right? The individual is not relaxed, right? I'll show you one more ECG similarly. Right? You see here, this is also the effect of shivering, right? The spikes are more exaggerated than when a patient is not relaxed. When patient is just moving like that, you will have the ECG what I have shown. But when the patient is like shivering, then you will have the ECG in this following manner. The spikes are more exaggerated than when a patient is not relaxed. Okay. So these are like artifacts. You don't have a problem in the patient's heart. You need to try to correct all these before considering that there is some abnormality in the patient's heart. Speed should be 25. Calibration should be 10 mm. The individual should be completely relaxed. Leads should be properly placed, right? They should have good contact. The individual should not shiver. These are the things what you need to take into consideration before considering any abnormality within the patient. So these are some of the points related to your ECG basics. And in my subsequent sessions, what is that I will be discussing? Right. In my subsequent sessions, I will be discussing all these. Right. So how to calculate the rate? right? How to interpret the rhythm, how to calculate the axis, then abnormalities of the P wave, abnormalities of the Q wave, R wave, T wave, U wave, then what is Osborn wave, what is delta wave, what is epsilon wave. So these are all the things what I will be discussing in the subsequent sessions. So this session was just only the basics: ECG paper, ECG machine, what should be the normal leads, how they should be placed. So please follow my subsequent ECG sessions, that is about the abnormalities. Thank you very much.